My name is Jordan Karlitz. I am an associate professor at Tulane University in the Division of Gastroenterology, and I'm director of the GI Hereditary GI Cancer Genetics Program at Tulane University. So a few years ago, we utilized Louisiana tumor registry data to try and see if younger patients, patients under age 50, who would be at the highest risk for Lynch syndrome. We were trying to figure out if they were getting screened for Lynch syndrome if they had colorectal cancer with microsatellite instability testing. So we published this manuscript in the American Journal of Gastroenterology in 2015, and we showed that only about 23% of patients with colorectal cancer who were early onset were getting screened for Lynch syndrome, which is very low because the number should be 100%. So as you know, if you have early onset colorectal cancer, up to 17% of patients can be Lynch syndrome carriers. And now the current recommendation is actually to do MSI testing on all patients regardless of age. So given the results of that study, we were trying to figure out why this may be occurring, why these rates were so low. So we figured the best thing to do would be to send out a survey, and we decided to survey mainly gastroenterologists because they're often the first to diagnose colorectal cancer on colonoscopy. And basically we asked them a number of questions of what are the types of barriers that may interfere with the ordering process of microsatellite instability testing. So we sent out the survey. I believe we got about 500 responses, and we found that the most common reasons that were preventing MSI ordering were cost concerns that the providers had, concerns about potentially not being able to interpret the results, concern that there weren't enough genetic counseling services available for the physicians to assist with the physicians' interpretation of the test results. Another key barrier that we found for a barrier to MSI testing being performed was something we called diffusion of responsibility. So we actually asked survey respondents who they thought should be responsible for actually ordering the MSI testing. And we got a wide array of answers. So some people thought the pathologist should be ordering it. Some people thought GI doctors should be responsible. Others thought surgeons or genetic counselors should be responsible. The GI doctors, they thought 38% said that it should be the pathologist, and 33% said it should be the GI doctors. And then there were several other responses, as I mentioned before. This is concerning because this means that one person may think the other person's ordering the test, or the other specialist is ordering the test, and the other specialist may think the other specialist is ordering the test, and then what happens is that it just never gets done. And we also look to see where these kind of barriers clustered, and they seem to cluster in non-academic and rural settings. And we also asked some questions about whether or not providers thought that the testing should be done on the colonoscopy as opposed to on the post-resection surgical specimen. It's important to try and do it on the colonoscopy specimen because you want to try and identify Lynch syndrome preoperatively. So microsatellite instability testing is just the first step. You still have to do germline genetic testing, but ideally you really want to have everything, all these test results expedited and in place so that you can make risk-benefit decisions about extent of colonic resection before the patient goes to the operating room. Because as we know, if you only have a segmental resection in Lynch syndrome, there may be a significant chance that you could develop a second colon cancer. So we found out that only about 46% of our survey respondents felt that the testing needed to be always done on colonoscopy biopsy specimens. So those are really the kind of interesting findings of our study. Answer. Number one is one of the things we concluded from the study is that it's important to try and have reflex testing available at institutions. That means automatic testing, right? So that there are protocols set up so the testing is automatically done so no one has to order it. The other issue is we need to make sure that even if the testing is done, that someone is designated to act on the results, because there have been cases in the literature where someone may have abnormal microsatellite instability testing and no one acts on the result. For patients, I would make sure that they are as educated as possible with regards to the risks of this syndrome and other syndromes as well, because there are other syndromes, not just Lynch syndrome, that are associated with hereditary colorectal cancer and other cancers. I would say that they need to be their own advocate and make sure that if microsatellite instability testing is not done, that they ask their physician, this is something that I've read about, this is something that's important, but encourage patients to learn as much as possible about colorectal cancer, about the risks of hereditary syndromes, and how to work it up.